Hello, good morning everyone. I guess you are a doctor or medical professional, so that you are interested in this topic. I am Dr. Sapan Samanto. I specialize in invasive procedures. I generally do biopsies and procure surgical samples for diagnostic purposes from very deep-seated and critical areas like liver, lungs, breast, kidneys, spleen, anywhere you can mention, and especially from bone lesions, deep-seated bone lesions like femur, neck of femur, hip, etc., etc. This is my routine practice for last 10 years. What I specialize in is that the very critical and deep-seated lesion where the infrastructure is very limited, especially in third world countries where the doctors are often forced to work in suboptimal situation. This video is for those people who are interested in doing such invasive procedures with extreme skill and expertise and very quick procedure. This you can see in this video that I am not using any special equipment, very minimal equipment, and the price of the test is also very minimal, like only 10,000 for the whole package, starting from your CT scan guidance, your core needle, biopsy gun, anesthetics, and everything consumables, and including the histopathology also. I do the histopathology examination myself, and today I will discuss how to procure the very critical areas like neck of femur, especially in a female person, female patient who is very obese. Her body weight is 140 kilograms, and the lesion is almost 15 centimeter from the skin surface where your gun could not reach. So in such situation, we have to manipulate the standard procedure. Like first we have to assess, is it possible to do the হাঁটা চলা করতে পারে না না কিছু টিভি চিকিৎসা চলছে? হ্যাঁ চিকিৎসা চলছে। হ্যাঁ কতদিন থেকে কি কাজ করছো কিছু জানো? This is one example of terminally ill patient where quadriparesis is there, and the patient you can see that he is catheterized, and everywhere there are needle pricks like that. And in India, no tuberculosis cases are treated properly, and most of the cases recur within 1 year. BLR অফিসে কাজ করতো। আচ্ছা BLR অফিসে, তারপরে ক্লার্ক। এর আগে টিবির ওষুধ খেয়েছিলে? না, but we have to do the procedures and confirm the diagnosis, otherwise the patients are not treated, and the consequences, they die very early. Just note the depth from where the tissue or collection should be collected. We have to pass through the length of the tissue. ওজন আমার তো মনে হয় 30-35 কিলো হবে। হ্যাঁ biopsy to procure the samples, or could it be some adequate sample for immunohistochemistry by other than histopathology, immunohistochemistry and molecular test. So first, before taking the patient, we have to judge the case individually, and very we have to scrutinize the case with thorough clinical examination, because the patient is already almost bedridden, and you can see we have to do the procedure from either posterior medial or posterior aspect, because the lesion is on the posterior lateral aspect of the neck of the femur. So first my question to the patient, other than any otherwise, if the patient is otherwise fit, like blood pressure, bleeding tendency, whatever, etc., all are okay, but the patient is able to take the prone position or not? That is my question. So with very difficulty, the patient, yes, could take the prone position. Otherwise, I had to do the procedure from lateral aspect or posterior medial aspect. That could be very because the biopsy gun could slip on the surface of the femur, cortical surface. Please note the history of the patient. She is a case of post-mastectomy breast cancer, treated with radiation and chemo, and now presented with a foot drop or right leg, and she is having this active area as per PET CT scan only in the right neck of femur. Otherwise, she is normal, nowhere any lesion. And another point to discuss, to consider the obesity or the distance of the lesion from the skin surface. In this case, the distance was almost 14.5 centimeter. That is quite big, and the core biopsy gun, the needle portion is almost same size. So it is very long distance to traverse the soft tissue part to reach the lesion, and then I have to fire the gun under that, also under CT scan guidance. So now 2 points here, the difficulties. Patient is of poor socioeconomic status, so she has limited budget. In India, the case is done with only 10,000 per case, including everything, all medication, CT scan guidance, biopsy gun, procedure, and histopathology report. Everything within 10,000. I have to do the procedure within 5 to 10 minutes because large number of cases are waiting outside. And this is the situation in India. We have to do the procedure very quickly, safely, and as OPD proceeds, and no complications, so that the patient is not admitted, do not need any admission to otherwise the further costing will be increased. So coming to the point, so the patient has taken prone position. Now before procedure we have to scan. Yes, these are all long or lengthy needles that I use to administer local anesthesia in cases of deep seated lesions. You can see the lesion is quite big. It is not that small, but the area is a mixture of osteolytic and osteosclerotic areas. So from the point of view, from the aspect of biopsy procurement, obviously I have to target the osteolytic lesion, because osteosclerotic lesion is not penetrable with the biopsy gun. So you can see that I have to infiltrate the overlying skin, soft tissue, as well as the periosteum of the location of the lytic lesion with local infiltrate, local anesthesia. How should I do that? See, the normal hypodermic needles are only 2 to 3 inches, and that is all. So now that is the maximum. So I have to take either very long needles or spinocane needle, and মাথা দিকেও আছে, পায়ের দিক দুদিকে আছে, তা আমার সেন্টারে আছে। চলো, reach the skin surface or adipose tissue to reach the cortex. First I have to infiltrate the periosteum with 5 milliliter of local anesthesia and surrounding muscle tissue. Then another 5 milliliter of this local anesthesia is required for the adipose tissue and the overlying skin. So now I have to locate the appropriate area with the spinal needle. So you can see the needle is just 1 centimeter 2 centimeter away from the lesion proper. So now with the while inserting the biopsy gun, I have to check the gun has reached, the tip of the gun has reached the lesion or not, with a sound that it will be tick, because it will hurt, it will hit the cortex of the bone, and that time I have to ask few questions to the patient. What are those? Is he feeling any difficulty like electric shock, like tingling pain, burning pain, or very shocking pain, or severe pain like that? Because the nerves, bundles and vessels are in this region only, so this is a very critical location. So I have multiple times I have to check whether the patient is feeling any severe discomfort like that. Yes, in this case she is not having any problem, she is okay with that, because while firing the gun, it is not that only one point I will hit. I have to take multiple samples from a radius of at least 1 centimeter. I generally take 6 to 8 course, because from the point of histopathologist, it is very good to have multiple course, and that also at least 2 centimeter long. In this case, so after checking the compatibility of the patient, if it is she is compliance okay with the procedure, then I have to firing. So multiple times you can see the tissues. It is not that every time you will get very good tissue. Some mixture of surrounding fat tissue, fascia, periosteum, muscle tissue, everything will come along with the bone fragments, and then the very nice glistening grey white tissue pieces. Those are the, I think those are the tumor proper or the lesion proper, whatever. I generally take imprint smears to further confirm the material, if it is fine, the procedure is successful or not. It will take only 10 to 15 minutes to stain the smears very quickly, and you can see yes, the sample is okay, because there are so many malignant cells in the smear. So during the this is another uniqueness of mine that I follow. During the tissue procurement, I generally, you can see I am counting the centimeters and before firing the gun, and after procuring the tissue, when the tissue has come, I take some imprints on the glass slides for confirmation, as well as visual inspection. If the tissue is grey white, necrotic, it immediately can confirm that the material is okay. And if there is any confusion like cartilage or fatty tissue or surrounding muscle tissue or ligament tissue, then obviously we have to confirm it by staining immediately. Perioperative staining, it takes only 10 to 15 minutes. Any stain you can use, and this way we confirm the tissue, and no need to recall the patient or costing, everything is minimized. So please consider this technique also when you are doing biopsies for such difficult cases. It is really difficult to call the patient again and again and take the tissues. Everything will be doubled, including the cost and time, everything. So please follow my rule and take some imprint smears and stain it immediately if you are histopathologist or cytopathologist. You can do it yourself and confirm. It will build confidence within yourself, and that is very great, professional satisfaction. Thank you. Dear friends, can you see the peroperative imprint smears? That those are stained within 15 to 20 minutes, and we can see the cellular smears and perfect imprints of the linear course. The smears are literally packed and crowded with cancer cells. You can see the clusters and scattered so many discohesive cells. Needless to say that these are all cancer cells, and in closer view you can see the polygonal and round shaped tumor cells with prominent nuclei. These are nothing but metastatic breast cancer cells. Procedure: some technician goes to the lab and takes a very quick staining, MGG, GIMSA or Neosin, whatever, and I check. After this procedure, I ask the patient to wait for 10-15 minutes. I wish all histopathologists and cytopathologists are trained with such procedures so that they can procure themselves the tumor issues, and they are the best people to assess the adequacy of a surgical biopsy sample. So I request all people in this field to be trained with this technique. Thank you. Check the slides. If it is okay, then I ask her to leave. Whatever, after the procedure, after 8 to 10 course I have taken, you can see the tissues. I ask the patient if any complication physically, if she is feeling anything wrong, like very unusual pain, very electric shock like burning sensation, anything can occur, but generally does not occur. That is because during procedure we have to feel what is happening inside. You can feel with the gun, its sound will tell you if anything is wrong. So the patient in this case says no, nothing, no problem, and that after that also we take a repeat scan. After the procedure, post-procedure scan, we can see there is nothing, no hematoma. Hematoma, it would be whitish loosened area. There is nothing. It is same as previous before the procedure. What was we compare the two films. But in this case it is okay. Nothing is there. No hematoma, no fracture, and patient is also not having any severe discomfort, pain or burning sensation. Same and the foot drop is degree of foot drop is same. It is almost 80-90%. She has had a foot drop. It is same as before. So in these cases we ask the patient to take a supine position for 10-15 minutes, and then ask we check some vitals. If anything is, everything is okay and the smears are confirm the material, then we ask the patient to leave with if you are experienced enough, immediately you can see or feel that the tissue is sufficient, and you can ask the patient during the procedure if she is feeling any pain or discomfort like that, and immediately you can change or check it with the CT scan machine. And I think everybody should follow this technique while doing procedure. Just keep talking to the patient so that you can detect very early that she is having some problem, because you are taking some tissues from her body or his body from so deep seated. It is quite very deep. You can see the depth of the lesion. It is very far. Some analgesic required. That is the procedure. You see the video and comment. I perform generally such a difficult biopsy procedures, and I am doing this for last 14 years. So many lot of them very critical and rare cases I do myself, and this is kind of signature procedure that I do. Totally completely different kind of this local anesthesia infiltration and the biopsy procurement, and that also within 10-15 minutes with very limited infrastructure. I think this could be very useful for the doctors in practicing in third world countries. And please comment and share and like, and if you want to watch such exceptional videos on invasive procedures, very exceptional and rare kind of things, please subscribe, like and share. Thank you so much.